Okay, welcome everybody. I'm going to turn over the mic. This is the Ask Me Provider Network meeting. I'll hand the mic over to Dr. Kelly Cowan.
Hey everyone. Welcome to session 2 of our course for asthma self-management education skills to support students. Today we're going to focus on Karen reviewing asthma self-management education delivery, and then we'll focus on tools for trigger reduction. Last week during our session, we ran out of time going over some of the devices. So if there's some specific devices that you guys would like to see, we'll give an assortment there and we can show some video demonstrations, or we can, if you prefer, we can share how to find the videos if you want to have review on your own. But if you want to do that in the group, we can do that as well. So next slide, Karen. This is our monitoring form to let you know that the speakers today, myself, Karen, and Melissa Barron, our nurse asthma educator, have no disclosures. Next slide. And an overview of what we're covering here is for our first session, we talked about asthma basics, medications, and devices. Today we'll focus on the tools for trigger reduction. We'll come back to that initial piece about delivering asthma self-management education and how to track that in a way that's meaningful for your students. And then we have a session open next week to cover anything that we need to come back to, anything that we missed. And if there's any specific cases you would like to discuss, anonymously, of course, without patient or student identifiers, or things you'd like me to cover. Otherwise, I'll be available to share some cases and take any questions. So feel free to pass those along to Karen or I, and we can put that together for you for next week if you have any specific questions. Otherwise, we'll be here for that discussion. And I'm going to turn over to Karen now to talk about asthma self-management education, delivery, and tracking.
Karen, you're mute.
I think Karen, you're muted.
Right.
Karen, can you unmute yourself? You're muted.
Thank you. Did you hear my introduction or did I mute myself after that?
No introduction.
No introduction? Oh, so I'm Karen
Okay.
Casper, the Respiratory Health Director at the Health Department, and we're excited to have a new asthma program manager who's on Kanika Valley, otherwise Valley, and so in the future you might be seeing her in future rounds providing some of this training, but for the time being, I'll be sharing some slides today. I might be muting you as I go along, but feel free to come off of mute if you have any questions. This section will be on asthma self-management education. It's supplementary support for uncontrolled asthma. And it's really intended to be separate education from a standard doctor visit. It's intensive, it's supplementary. It requires a minimum of 2 sessions for the learning, but they can be brief. They can be, 5 to 10 minutes, and usually cover some of the basics that we're actually covering through these sessions: asthma basics, asthma medications, proper device use is a key skill, asthma triggers, and daily management of asthma. And so the aim of the intensive ASME short for asthma self-management education, is to improve asthma management skills as well as knowledge. And skills can include things about how to assess your control, how to perceive or what symptoms to look for, skills in using the devices properly, knowing the difference between medications, and being able to select and use those devices as needed or as prescribed, and following an asthma action plan. And the knowledge is more about what is asthma, what do the medications do, and what are common triggers and things like that. So when we promote Ask Me, we're looking to address those students with uncontrolled asthma. They in Vermont, uncontrolled, I don't see the data slides here, but I can, we'll talk about that at maybe some future time. But for Vermont, we have high asthma rates in general, highest in the state. We're in the top 10 states, hovering around the fifth, sixth highest. And so which is a high enough burden. But worse yet is that about 61% of our kids with asthma have uncontrolled asthma. Those students with uncontrolled asthma are much more at risk to miss school days, bad sleep, low performance academically, and emergency exacerbation. Ask Me is really designed for those kids with uncontrolled asthma or other high-risk individuals of any age. And then there might be certain children and or families that need extra support than just at the doctor's visit to help them understand what's required for their managements. For example, there might be health literacy challenges or cultural beliefs that or social and environment needs and other challenges that cause some complications for families or individuals to adhere with their treatment plan. The first step in delivering Ask Me is to identify at least one student with uncontrolled asthma. The second step is to carry out some sort of ideally objective assessment of asthma control. And there are various tools. We like to have folks use the ACT asthma control test. And this is available online, and it's really kind of fun to use. And then the second pre-assessment is just to have a student show you how they're using their device, and to make a simple assessment, is it correct or not? And there's a variety of issues that occur, not breathing in proper timing, perhaps not using spacer when you really recommend that they do, and not checking the counter to make sure the device has medication still in it. So there are quite a number of things that you can do. Kelly, do we have time to pull up the score? Should we hold that off for next week?
Go for it. Yeah.
Okay.
Let's go for it.
Let me see if I can, let's see if it's active. If not, we'll wait and see. I should have done this before. But this is an example of this tool, and it's very handy. It's got this ability to choose, are you assessing for an adult or a child under 12? And then you can do next, and it gives you some guidance, about what steps, and they'll score, they can send you a report. But basically you say, how is your asthma today? You're asking the student with uncontrolled asthma, and they say, it's not very good today. And then you move on to the next question, and how much of the problem is related to run? How much of a problem is your asthma when you run, exercise, or play sports? Yeah, it's a little problem, but it's okay. I'm just making these answers up. Oh, do you cough because of your asthma? Yes, most of the time. And then do you wake up during the night because of your asthma? Yes, some of the time. And then during the last 4 weeks, during the last 4 weeks, how many days did your child have any daytime asthma symptoms? Some of these tools do engage the parent to help ask this, but the students usually can also help, directly answer these questions. So in the last 4 weeks, how many days did your child have any asthma symptoms? We'll just say 11 to 18. And during the last 4 weeks, how many days did your child wheeze during the day? We'll say 4 to 10. And during the last 4 weeks, how many days did your child wake up during the night? 1 to 3. And then you see the final score. That's automatically approved. You can print your results. Now, the most asthma control tests are really bifurcated. They just have controlled, well-controlled or poorly controlled. But this test has kind of a nice three-way, although really anything in the red or the orange or yellow is really poorly controlled. So they do would benefit greatly from supplementary education. But you can see that what's ideal here is for well-controlled is 20 and above, and this child would be not well-controlled. And then it can print this and then share with a parent and then suggest, additional time spent with them in working on the asthma control test, on the asthma self-management education. So just 2 pre-assessments. The proper device use is important because that's how they get the medication to their lungs. So you want to make sure they can actually do that. And an objective test, ideally, for asthma control. Some of you can do a subjective test, but it's best to get into the habit of using periodically objective test. Then you would want to deliver ASME to your uncontrolled students. And we've developed a curriculum for a Vermont curriculum based on American Lung Association validated materials. And we have the curriculum in 4 5-minute videos. And we've also developed kind of a checklist document called ASME in Schools Packet. And this is kind of gives you like little squares and check marks to check off key messages that you would share, and gives you kind of an outline of what is ASME. And these resources are available to you if you were to want to deliver ASME to at least one student, and it's a challenge for you. So what you would do is there's forms on that ASME in Schools packet, just 2 forms. One is the name of the student, some basic things about other ways you might assess whether they're at uncontrolled, like did they have an emergency department visit recently. And then here's the pre and post test, and then tracking the delivery of content. Like if you delivered 2 content elements on the first day and 2 on the second day, that qualifies for completed education. And then you do a post test, and then if possible to do a 1 month after the fact, 1 month later, recheck them. And that checks for sustained asthma control. And usually the curriculum does produce sustained asthma control. So it's a very positive intervention, and it's worth your time to help those students. It helps them with their skills, their knowledge. It can sustain asthma control for up to 12 months. And we've seen that in our own work with through different partners, and they've seen 12 months of sustained asthma control. It can improve the kids' quality of life, their academic performance. It can help them with any activity limitations they might have faced, and it can also reduce risks of those emergencies, including emergency department visits. So here's some just focus on the increasing bar height. The first bar shows their first pre-test of asthma control. in different kinds of programs. And then the second or third session keeps improving asthma control over time. All of them, all of these different strategies in different settings produced improvements. The bottom group of data is data from school nurses. And you can see this middle chart showed improvement in asthma control from 25%. The green is the pre, and the turquoise is the post. And you can see quite a significant improvement. And then the spacer use, we were really promoting spacer use. And so those increased significantly to 100%. And then the color changed, changed here. And then proper inhaler, the green is the post-test, and it went from 64 to 97%. So huge improvements in a very short period of time with little investment. So how can you start delivering asthma? You start with one student. You identify one student that seems to really be struggling with uncontrolled asthma, and you set a start date. Put it in your calendar. I'm gonna deliver in 2 sessions. We found that if you set a start date, 100% of school nurses actually carry it out and complete it for a student. So just do those 2 things and you'll succeed. And then, you know, walk through that Ask Me packet, and you do the assessment, then record, and then deliver the content, and then assess the post-test, and then record it. And then if you would send it to me, we can keep a record and continue that, seeing if we're seeing improvements among students. Oops. So there are various supports. You want to send me a note asking for the Ask Me in Schools packet. We can get you those links to those 5-minute videos that you could maybe, if a kid comes in for help with their inhaler, you could show them a 5-minute video and pull it up and watch it together. And that counts as the curriculum delivered for that topic. So that's Ask Me. Shall I stop here and see if there's any question, or for interest of time, shall I keep going, Kelly? Dr. Cowan?
I think if there's questions, you can put them in the chat and we can pause and answer, or we can come to them at the end, or raise your hand.
Okay. I'll keep going unless someone just is bursting to ask a question, then we can get to it. All right, so today's session is meant to focus on asthma triggers and its connection to asthma control. So as I mentioned, there's 60% of children at any one time that have uncontrolled asthma. This is very concerning to me. We know that 51% of children with current asthma has had an exacerbation in the past year, and 38% of children have had an asthma exacerbation in the last 3 months. And these have been exacerbations that have lasted for anywhere from hours, days, or weeks for more than half the children. So they're really kind of struggling. We see that almost 1 in 2 kids have a report having activity limitation due to their asthma in the last month, which makes my heart break for kids who just want to play. And then 1 in 6 kids who have difficulty with sleep disruption, which can then cascade to poor concentration, behavioral issues, other kinds of, and moodiness and things like that. And almost 1 in 3 kids have missed at least 1 day of school in the past 12 months. Some of the triggers, we periodically do this survey, and we find that more than half of children are exposed to the top triggers, and those are indoor pets, pets in the bedroom, and carpet in the bedroom. And another 84% of children are exposed to 2 or more triggers at home. We try to suggest that if you are working with a kid who seems to be really reactionary to environmental triggers, that you try to guide or coach about reducing, 1 to 3 triggers, and that can really help them with progress, just to get that ceiling down a little bit for them, give them a little bit of room for easy breathing. Note that tobacco smoke, vaping, and other secondhand smoke are widespread Vermont triggers and can trigger asthma. We know research that suggests that that smoke and vapors can contribute to new asthma cases, and just really affect the environmental, a family's respiratory health. So we have developed a program called Asthma Friendly Schools Recognition Program, and it sets out a whole bunch of best practices that if you check them off, you can aim to try to be recognized as asthma friendly. Most schools do qualify at the bronze level just for work you already do because of regulations, the law, things you've done because of COVID days. And but you could also take a look at that list and work through the year to add and go for gold. And technical support is available. And once you've achieved it, then your school is listed in a little interactive map we have on our webpage. And there's our webpage to tell you what that criteria is, and to really brag about the schools that have achieved a bronze, silver, or gold level recognition. The deadline for that every year is May 31st, so you have time to work on it. Some of the key best practices are collecting and keeping on file up-to-date asthma action plans for, and there's like 3 points you could get: 50% of your kids with asthma, 65%, and 80%. If you have 80%, you get 3 points for that, just by virtue of clicking each of those. Some things are easy, like enforcing tobacco-free and idle-free policies. And some things are intermediately challenging, ensuring that schools only purchase third-party certified, safe, and green cleaning products. And some things are a little bit more challenging, which is carrying out an annual Envision environmental walkthrough, which is, I'll show you in a second. And then lastly, delivering ASME to at least one student. So one of those harder ones, but still really beneficial, extremely beneficial, is carrying out an Envision program walkthrough, an environmental walkthrough. Kelly, do we have time to show this video?
Yeah.
So this is a video starring a fellow school nurse. Let me see if I can get it to go. If it's not that way, I'll go this way. Oops, that didn't work. Always have a backup plan. Can you hear that? Can you hear it? Okay, let me go back out and you hear it?
Even healthy students can be impacted by indoor air pollution. Our students with asthma and allergies, we need to be very mindful of. We notice an increase in kids coming down with headaches. Sometimes they just might not feel like themselves. They might feel more tired, not able to focus. We really wanted to make sure we were doing everything we could to have a healthy school. So we reached out to the Envision program to help us. Let me show you around. We're so thankful to have you here.
Yeah, thanks for having me.
This is Michelle Thompson of the Envision program.
So one of the first things to look for when we come into a school is walk-off mats. Most of the dirt and dust that comes into a school building enters in the entryway. So if you have walk-off mats down at the entryway, that can help prevent dirt and dust from getting into other parts of the school building. So blocked ventilation units is something that we commonly see in schools. And while these are nice storage shelves, it's important to keep them clear so that fresh air is constantly coming into the classroom. Disinfecting wipes are another common thing that we see in school classrooms. And while disinfectants have their place in a school building, because of the chemicals and the fragrances that they contain, they're generally not safe for general classroom cleaning, cleaning off the desks and the tables. And they certainly shouldn't be used by kids. So you want to make sure that your cleaning products are certified by a third party that says that they are environmentally preferable and healthier for students, staff, and the environment. And these are great examples because they both have that third party certification. This is exactly what we want to see. So this is great because the air intake is not blocked at all. A lot of times what you'll see in a school that has ground level air intakes is landscaping that grows up along the building and blocks this vent. Or sometimes there might be a parking spot here and you could be pulling in potentially bad air. So this is perfect. So one thing that can be helpful in a bus loop like this is to have signs up to remind the buses and parents dropping off their students to not idle their vehicles. And that's important, especially on school grounds. If it's close to the school building, that air can be pulled into the classrooms. And if it's close to a playground, that air is around where the kids are playing. So just having that reminder is usually enough to help fix that. So there's a few things that pests need. They need food, shelter, and water. And one great way to eliminate their shelter is by having a strip like this or some sort of gravel strip along your school building. And that prevents vegetation from growing up against the building and being a place where pests can hide and shelter.
You can do a complete inspection of your school using our online checklist, or you can ask the Envision program for help. If you answer yes to a question, you're following the best practice. If you answer no, a recommendation pops up.
So as you can see, most of the things that we found at your school today were easy, low-cost fixes that can help improve indoor air quality here at the school.
Yeah, so that's the Envision walkthrough. Very easy to implement, carry out, and it's ideal if a school nurse can. A number of things relate to health and training, but it's also helpful if you were to engage or suggest a facilities manager or groundskeeper. Grounds director carry out an Envision walkthrough with you, or do team tag, and you do this part, I'll do this part. It's helpful, almost easier if you work as a team and walk through together, and then just go click, 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 yes, no, and then the product actually can be printed out and serve as a future plan of action for your wellness committee or other teams, staff teams on your in your school. And it counts as an asthma-friendly school best practice. So we have worked on a number of elements to try to improve students' ability to breathe easier and to manage their asthma. And those include the asthma-friendly schools. We've provided this interactive map. If you take a look, and if you get a medal of bronze, silver, and gold recognition, you'll be listed each year on the map. And then we're looking for universal participation in Envision, and we are seeing an uptick in those numbers. And we're aiming to have up-to-date asthma action plans for all students in a school. We have other resources at the health department to help when you see issues with a student, including referral materials to help families deal with quit attempts for smoking or vaping. And we know that youth younger and younger are beginning to engage in use of these products as well. So they may also need the supports, and they are designed, age-specific supports are available. And we have those three copy pieces of those asthma action plans. If you want those, you can just send me an email, and or in the future, Volley can be sent an email, and we can have those shipped to you through our warehouse. And then there are other educational materials, including brochures on triggers, home triggers, and little pocket guides for helping to discuss with a student about how to better manage their asthma. Kelly, Dr. Cowan?
Yeah, and I was going to come back and review some asthma triggers and how the trigger reduction relates to the asthma guidelines and the 2020 updates. The common triggers we see most commonly being viral infection, smoke exposure, exercise, allergens, and air pollution. Next slide. So just a note about viral infections and why this can be so challenging with school, and why we really focus on those maintenance medications, particularly during the cold season. And airway hyperresponsiveness in kids with asthma occurs after common infections, and the duration of the airway being hyperreactive after a single cold can be, from a number of weeks to a few months. So 5 to 11 weeks of increased airway hyperresponsiveness. So just treating for a short time with maintenance medication doesn't always help. After multiple colds, the airway hyperresponsiveness can remain elevated even 6 months. And we do see the prolonged viral-induced airway hyperresponsiveness in children with allergic disease also can contribute to asthma persistence. So this is, we're focusing on, knowing whether they're receiving maintenance medications. Assessment of asthma control can be really important in working on reducing missed school days and minimizing symptoms at school, and overall understanding how these viral infections can affect kids when they've had back-to-back illnesses. Slide. So the last asthma guideline updates didn't have a lot to build on in the recommendations for indoor allergen mitigation and the management of asthma. Mainly the focus here is to look at mitigation strategies for kids who are sensitized to an allergen or who've demonstrated symptoms around exposure. So meaning if you don't have allergies to pets, removing the pets won't fix the asthma, if that's not a trigger for them or their asthma. But focusing on things that do affect the individual child. Resources for testing can be difficult. Not everyone has the same access. So being mindful of deciding whether this child has environmental triggers or not, and having the family be able to assess that is important. Where things can be helpful, and there's higher evidence for pests. So like Karen showed in the Envision walkthrough, like reducing, where pests can get in. But pests like mice and cockroaches in the home, integrated pest management is a good allergen-specific mitigation intervention that would benefit children who have sensitization to that. And then for indoor allergens that are identified as a trigger for a child or suspected as a trigger, the guidelines focus on multi-component allergen-specific mitigation. So this is identifying indoor allergens, including dust mites. We all like to try to recommend, dust mite covers or things, but really that has to be part of a multi-pronged strategy to reduce those allergens. Next slide. So what are some strategies that are multi-pronged for these? So dust mites, those are triggers year-round, but those can peak in the fall, so that can mimic other allergen peaking in the fall. And the multi-component strategies for that are the pillow and mattress encasements. A big one is washing the bedding in hot water weekly, minimizing the carpet, curtains, and stuffed toys. keeping humidity under 50%, and HEPA filtration of the air isn't helpful here because this is a surface area. So just HEPA filtration alone is not going to fix this. For animals, that's a year-round trigger. We recommend eliminating or reducing the carpet, using a bedroom HEPA filter for the child, and the common area is probably helpful as well, but if you're choosing a place, we tend to recommend the bedroom. Pillow and mattress encasements can help, a HEPA vacuum, and trying to restrict the animal from the bedroom, which is really challenging when you're trying to circulate air in the home. With molds, a big one would be to maintain humidity, 25 to 50%. That can be challenging because sometimes you're dealing with whatever just is naturally occurring in the home, but you have to think about if you're in an area that needs a dehumidifier, trying to minimize use of spot humidification, like children's humidifiers, for if you really need it, if the air is extremely dry. I have a little picture here of a hygrometer. For where this is, if this is a concern for families who are interested in looking at that, these are around maybe $10 for a small one. Sometimes they're on a home device already, but this they can move around the home and measure in the home and get a sense of what's happening in the house. Using exhaust fans in bathrooms to try to minimize steam, those things can be helpful in reducing mold accumulation. And then pollens, those can peak at certain times of the year, like tree grass and weeds. Bedroom exposures are important, like closing the windows. And if it's possible to use air conditioning, that can be helpful. Showering before bed, keeping windows closed in the car, trying to keep the exposure as low as possible. And then for mice and cockroach, it's the integrated pest management. Next slide. So when we think in our clinic about what families can do and what options they have for checklists and tools, we've done some of our own structured questionnaires sort of based on these more detailed checklists to target key factors, really to facilitate discussion. Some of these would be around smoke exposure, smoking cessation, pests in the home, things like that, things that have a pretty straightforward way to address. And if you want to click through here, Karen, this is the EPA checklist. This is one option for a detailed checklist that families can be referred to. This is actually a checklist that's developed for home visitors, but it does give the families, Karen, you can just click through my slides, actually. I just put them there for us. These are designed for home visitors, but also helpful for families because they can look at these and see some things that are lower cost, things that can be done, or things to make things a little bit better at home. In learning about their home and learning about different air triggers in the home. And I do like this because it does give some potential strategies in the home that could reduce some of the triggers. And we can click through these next two slides, Karen. These are to demonstrate what's available on this checklist. And not an expert. I have an interest in the environmental triggers, but not an expert in all of the home remediation options. And this has been helpful for me to be able to go through and see, what are some reasonable actions families might be able to take on their own. And a lot of the options here are appropriate for renters and homeowners both, although renters we find tend to have a lot more difficulty with environmental triggers and not as able to remediate. Next slide. Karen talked about those important resources for smoking, vaping, cessation. That is still an extremely high priority to address, but it was something not addressed in the updated guidelines. And then other indoor air pollution, aside from multi-component allergen reduction, was not addressed. Next slide. So we'll talk about air quality here for a little bit. So we know that's a major factor in a lot of health outcomes. So respiratory disease, cardiovascular disease, and neurodevelopment. And some of the major components are coarse diameter and fine diameter particulate matter. The issue with the fine diameter particulate matter, PM 2.5, those are the ones that are less than 2.5 microns. Those travel really deep into the lungs and they cross directly into the circulatory system. So those have multi-system effects. So it's not just the respiratory system, but for kids with asthma, those can have pretty big impacts. So this is where that's just one of the pollutants that's really important for respiratory health. There's others, so VOCs, nitrogen dioxide. One of the example here to share is that the relationship between PM 2.5 and nitrogen dioxide in lower respiratory tract infections, sinus symptoms, asthma symptoms, and allergic symptoms. And kids are inside a lot, and that becomes a significant source of particulate matter exposure for children. And these are things that even if the house or school looks or smells clean, the particulate matter is just a normal byproduct of activities like cooking, cleaning, heating, and learning about where some of these triggers come from is helpful. Next slide. So the main places this is coming from is combustion sources, also with cleaning. We know that homes with more pets have more particulate matter. So reducing the combustion sources, so wood stoves, so that's would be one example of a source of particulate matter is pretty obvious. The type of wood stove, age of wood stove can have some impact on how much particulate is coming into the air. And then also what the wood stove burning practices are. And in our clinic, a lot of people do have more than one heating source. Some people only have a wood stove and they really just do have to heat. So then it's thinking about how they're burning the wood, trying to filter in their home, HEPA filtration. If we can't eliminate the wood stove, there are some change out opportunities, but it's not an option for everybody. And often our patients will be calculating the cost for heating in the winter if they're using their alternative source versus a wood stove. And sometimes it does come out in favor of not using the wood stove, and that's tends to be more helpful for asthma. But if not, we can talk about filtration or the burning practices. And then there's been a lot impressive in the last couple of years about gas stoves and nitrogen dioxide, that using the fume hood is helpful in minimizing that. So we're in favor of kids cooking and doing those things and cooking at home. So that's challenging to say that kids shouldn't go near it because it's generally good if the family's cooking together and doing those activities. So if kids have exposures, things would be the ventilation is really important with those. You can't really have a gas stove with no ventilation, but it does happen. That's not ideal. And then HEPA filtration with a carbon filter. The carbon filter reduces quite a bit the nitrogen dioxide. So there are some opportunities to improve the air quality for those kids. Next slide. And Karen has a cute picture here to see a typical home, I think, with a lot of triggers here. And you can see there's a dust mite. Those are really unappealing to look at. So usually people that are not allergic just want to not think about that at all because those are around. And then we see a lot of stuffed animals on the bed and those things. This is where getting a sense of whether children might be sensitized to these, how their asthma control is overall, if this is something to investigate or not, because it is, as you can see, to do environmental controls in the home is a really big deal. And to think about, for some kids, that has a really significant impact. If it's going to have a smaller impact, thinking about what the burden is to the family. But you can see a lot of ways in here, perhaps, to improve the environment. Next slide.
This just goes into this break session.
Yeah. So we have one session next week to finish up our December sessions, and then we'll have another round of 3 sessions. So we'll do the same set about the asthma pathophysiology and devices, and overview of the asthma self-management education, and then the environmental triggers will be the 14th and 21st, and then we'll have another session open for case discussions and whatever you want to bring or finishing up material on the 28th. And then we can pause for some questions, and then what we've added at the end for those of you who may want to go through any of the devices that we didn't get to look at videos for last time, if you're interested in seeing those, we're happy to go through that piece of information too.
I
We'll
also
take any
just,
questions, whether it's, yeah, go.
yeah, I just wanted to emphasize that we'll use similar content in the next round, but we try to emphasize something new each time to keep it fresh. So by that point, we hope that you will have identified, let's say, a student to deliver Ask Me, and we can use that time to provide technical support, or that you'll be able to review some of the issues, or begin to reflect on some of the students you've had in terms of challenges with medications, and or so it can be troubleshooting, a focus on troubleshooting, or whatever you bring in terms of cases. So we want to try to keep it interactive and unique, even though material seems similar. Um, the other thing I wanted to just highlight is some of the triggers we've discussed today are really about showing examples from homes, and your students are coming from a home environment where they're spending 2/3 of their time, and then 1/3 of their time with you at school. But some of these triggers, so coaching them about how to handle and dealing with home triggers is important. But also, a lot of these triggers that you see here in this example are also present in schools. For example, school I visited, there wasn't a cat, but in a nice little cage was a little hamster. And so the question is, if you've got kids with, sensitivity to pets, perhaps it's appropriate to have the pet kept in another location. And then you go and visit the pet or what have you. And then the kid is not entirely exposed daily for those 8 hours a day. So there are things that just be conscious about. A lot of these tools you can adapt for school environments, but the asthma friendly schools promotes the Envision program, which is designed specifically for school environmental walkthroughs. So with that, are there any questions about any of this content on triggers? Do you see a lot of kids who are facing exacerbations because of classroom setting triggers, or? We've also observed that with the coming out of the pandemic, there was a lot of emphasis during those years to try to keep everything clean, disinfected. And so we have seen a huge increase in a variety of cleaning supplies that have harsh and rough chemicals that may also be causing some kids some challenges. And so checking and confirming that they're as green and safe as possible is important.
I'll comment as a parent that over the last few years, we've been asked not to bring cleaning products in, where we were used to ask for specific items, we were asked to share for the classroom. And I think that's most likely to have certain, to avoid certain chemicals or things that are more irritating to people.
Yeah, it's very hard because it's like this lesser of the two evils, if you will, is the well-intentioned parents and teachers with low budgets, try to bring in products and materials. One of the points for asthma-friendly schools is for preventing parents and staff from bringing in their own products and ensuring that the purchasing and supplies are purchased according to green and safe product lists, so that by accident you don't introduce harsh chemicals that way. So good point, Dr. Cowan.
We can probably advance the slides a few and see, and we can just take a moment to look at the content from last time. We had um, what we were wrapping up with last time was about the device types. So this is switching gears from the asthma triggers, but a couple of the big things we wanted to cover in these sessions were smart therapy, which we got through in the last session, but also that many of us are seeing kids with different device types than we had previously. The typically most reliable in terms of administration and acceptance of the child is the HFA MDI used with a spacer mouthpiece, or a spacer and a mask if they're younger. But others that we're seeing pretty commonly, and this is typically due to insurance requirements and not patient preference, are like Respaclick inhalers, Respimat inhalers, FlexHaler, Discus, DigiHaler, TrustHaler, ReadyHaler. All these are breath actuated inhalers, and all the devices have a little bit of nuances in how to administer, but they do require the child to be able to do the maneuvers, and they do require um, the device is not as hardy, in terms of caring for it with the dry powder. Sometimes, so I think if you're seeing an unfamiliar device on their action plan, um, that what I have found that has been helpful to share with patients is online resources. So some of them are, if I like the resource from the company website for the device, then I'll use that. But occasionally those will be an older adult or someone that's not as relatable to the patient. So I've found that one example of other institution resources would be Boston Children's has an instructional video for each device. And if they just go to YouTube, Boston Children's, and then type in the name of the inhaler, that will come up. And they have resources from everything from Spiriva Respimat inhaler to a nebulizer to a regular MDI. So those have been really helpful to me. And even when we're going through our teaching devices, some of them have changed over the years and aren't quite the same. So this does give an up-to-date way for patients to be able to look at that. And a lot of times with a child requires practice over and over with the device. And if their asthma control is not good, that's one of the first things we look for in clinic is that the parent think they're able to use the device as intended. Did they already get teaching? Is it something where it seems like they could really practice with that? Karen, you can go to the next slide for devices. So this gives an overview of most of the things that are out there. I think there's maybe a few others, but these really include what we tend to prescribe, and it also includes common biologics. That those are the injectable medications. So if you see what someone's on, you may, not sure of the name, you could go, to a chart like this and see what type of medication it might be. So that tends to be helpful in finding out also if someone isn't sure what they have but can recognize it. This tends to be helpful. Next slide. So we'll talk about how getting the inhalers in properly really makes a huge difference. This is an example of just the what most people are used to seeing, the MDI with the spacer and mask or the spacer and mouthpiece. And with those devices, there's no breath hold. They're really easy to use for infants and young children. They're really easy to use for school-age children. Probably the only downside for school-age children is the size of the spacer. You lose about 70% if you don't use it with a spacer. Yes, these all get FDA approved without a spacer, but they don't work super well due to the technique kids use and adults. So they really do get delivered best with the spacer. This image shows what happens if you take it just in the mouth, and most of that's in the GI tract and very little's in the lungs. But if you're taking it with a spacer, because it's activated by pushing the button, it needs the chamber to suspend those particles to breathe them in, and then that goes into the lungs better. For those devices and in any device, you want them to check their counter and see how much is left. It's something to be aware of in the office too with their albuterol. Once it's on 0, these MDI devices will still spray. So if you're not seeing the counter regularly, it could be empty and not know. So for kids who are on maintenance therapy at home, those inhalers are typically lasting about a month. The mask fit is important and it should cover their nose and mouth and not cover the eyes if they're using a mask. Care for the spacer is important and that they're not putting in the dishwasher, just washing with soapy water. We do have them rinse their mouth or brush their teeth after inhaled steroids. Many kids do need to wipe their face off because their skin can be sensitive to it. And then we do think about what type of supervision they need and making sure they have enough medication for all the locations. And I think that this image is pertinent to technique for other inhalers. Now, this demonstrates the device with the MDI and what happens if you do or don't use a spacer. But this is a good example if, say, it was a breath actuated inhaler that is manufactured to not use a spacer, but gets activated by breathing in, that if you don't have proper technique, you can activate the device but not pull the medication in. So you're not getting, it may look like you're getting medication, but the child may not developmentally be ready to use that, or they may not use it correctly. And in that case, it looks like it's being delivered, but they're not getting any. So it would look like the first one. They're just swallowing it and it's not going in the lung. So the technique for all of these is super important. I think this is where focusing a lot of our teaching happens, is that being really good at using your device. And then we have some resources for that through UVM and VDH. Next slide. We have, this is an example for, we have some handouts that we put on our patient education at discharge about using the inhaler with spacers, more for people who are not as familiar with it. But we do find very often in reviewing that people have lapsed or forgotten. Next slide.
You're at a 2-minute
regularly.
warning. Yeah, 2-minute warning.
And then next slide. So this is just a continuation of that teaching. Next slide. And then for both of the spacers with mask and mouthpiece, we have videos in English and with Nepali translation and Somali translation. Next slide. And then we have time, we can pick if anybody wants to choose one of these videos to look at. Anyone want to pick one for the chat? As an example of a training video of how to use something. I'm going to call on Melissa if nobody picks one. All right, Melissa. Pick your favorite or most common. Want a QVAR? Let's do that one. Your first one, Karen.
The recordings will be available. Links will take about a week to get prepared and we'll send out through Caitlin. Can you see yeah. Can you see this?
This video will show you how to use the QVAR ReadyHaler. The QVAR ReadyHaler is a device used to give asthma medication. First, wash your hands. Hold the inhaler upright. The cap should be at the bottom. Open the cap. Do not cover the vent at the top. Turn your head away from the inhaler and breathe out all the way. Put the inhaler in your mouth and close your lips around the mouthpiece. Take a deep breath in. Take the inhaler out of your mouth and hold your breath for 10 seconds. Close the cap all the way. Repeat if more than one puff is prescribed, starting with opening the cap. Then breathe all the way out. Opening the cap is how the medicine is dispensed into the mouthpiece. When you are finished, rinse your mouth with water and spit. Check the back of the inhaler to see how many doses are left. The numbers will turn red when there are 20 doses left. That means it is time to refill the medication. Clean the inhaler mouthpiece with a dry cloth only. Do not get this inhaler wet.
Thank you, Karen. Yeah, so you'll see that all these devices have little nuances like that. Like the cap opens it, activates it. So this isn't something where you're snapping the cap back on and off like a regular inhaler. So I'd encourage you to check out different ones that you see for your patients. It's totally okay to have no idea when you see a new one. I don't always know when I see them, and I will look it up and look at it with the patient if insurance is asking for a new medication that I'm not as familiar with or I don't use every day, or if I prescribe it periodically and I'm not as familiar with the instruction, I will re-inform myself about it. So it's always good to have where your resources are to be able to look that up and get a demo. But I encourage you to check out a few of the devices and just see some of the differences between them and why they're challenging for different ages.
Okay, well, thank you, everybody. We're at past our time. We look forward to meeting with you all next week. The links to the videos will be provided. Also, if you have any trouble understanding how to collect credits, you can email me, and I'll try to provide that information through like a newsletter through Caitlin Coates' through the school news newsletter. And yeah, we'll see you next week. Bring case examples if you can, and take good care.